President Wilson, and yeah, we hope you learned something new and this inspires you to advocate for policy within Detroit. So let's go ahead and get started. Just a reminder, please keep your microphones and video turned off. And during the Q&A portion of today, if you're selected to ask your question, you can go ahead and turn your video and microphone on and ask your question. So today's agenda, we're just going to give you a few quick reminders for our organization, and then we'll follow with the discussion with President Wilson, where we've created some questions that we're going to ask him, and then we'll finish off with a Q&A portion with audience questions from you guys. Go ahead and type them in the chat throughout this presentation, and we'll go ahead and choose a few. And if you're called on, like I said, you can turn your video on and your microphone on and go ahead and ask that question. So a few upcoming events that we have, we just want you to mark your calendars now so you're prepared for the future. We have a general body meeting November 5th at 1 p.m. And then we'll have our Detroit water panel where we have a few special guests for you discussing water in Detroit, and that will be on November 19th at 1 p.m. And then Dr. Thomas Nichols from, I think it's Harvard, he will be speaking for us on December 3rd about communication and science policy. So that will be a great discussion to come to. So make sure you mark that one in your calendar as well.
So we had a survey last meeting. If any of you haven't filled out the survey, please take a picture of that QR code now. Just here's the current data on the left. So we just need more people to fill it out so we can keep track of our impact. I'll just give everybody a second to take a picture of that QR code.
And just a note, if you guys are interested in still sending that letter about NIH funding to one of these senators, please feel free to email us and we'll provide you with the template along with instructions on how you can get this letter out to these senators.
And if anybody wants to write a blog post on our website, just feel free to email us. I will post a link to our blog in the chat right now. So if anybody wants to take a look at what we've written so far, there's a few examples. So just email us at scipoldetroit@wayne.edu, and you can have yourself on the website as well. And here's our social media on Instagram and Twitter, as many of you have, most of you have seen. It's just at scipoldetroit. Our website is scipoldetroit.wixsite.com/Wayne, and our email is scipoldetroit@wayne.edu.
All right, I am delighted to introduce President Wilson. Dr. M. Roy Wilson became the 12th president of Wayne State University on August 1st, 2013. Prior to joining Wayne State, President Wilson served as Deputy Director for Strategic Scientific Planning and Program Coordination at the National Institute on Minority Health and Health Disparities of the National Institutes of Health. Previously, he was Dean of the School of Medicine and Vice President for Health Sciences at Creighton University, President of the Texas Tech University Health Sciences Center, Chancellor of the University of Colorado, Denver, and Chair of the Board of Directors of University of Colorado Anschutz Medical Campus. President Wilson also chaired the Board of Directors of the Charles R. Drew University of Medicine and Science and was acting president during part of that time. President Wilson's research, which we'll hear more about today, has focused on glaucoma and blindness in populations from the Caribbean to West Africa. He's a member of the National Academy of Medicine at the Institute of Medicine. He received his undergraduate degree from Allegheny College and a master's degree in epidemiology from the University of California, Los Angeles, and then an MD from Harvard Medical School. So please welcome me in joining President Wilson. Virtual class.
Thank you very much. Thanks for the introduction.
Thank you. So we'd love to hear some more about your background in science and training in medicine.
Okay, well, I was born and then I was a little boy and no, I'm just kidding. Let me tell you a little bit about how I got into medicine and epidemiology. So in high school, I used to read a lot, and I read a book called Passions of the Mind by Irving Stone. And it was a historical novel about Sigmund Freud, and got really fascinated by the workings of the mind, and started reading all the classical psychoanalysts, Carl Jung and Sigmund Freud and others. So decided to go to college to become a psychoanalyst. When I went to college, as you mentioned, I went to a small college, Allegheny College. At that time, because it's a small school, the psychology department wasn't very extensive, and it was very behavioral psychology oriented, or Skinnerian psychology. And I wasn't really interested in that. And so I thought that instead of majoring in psychology and becoming a psychoanalyst through psychology, I would switch my major in biology, go to medical school, and become a psychoanalyst through psychiatry. When you need a medical degree for psychiatry. So that was my intent. And then it was raining one day, and I was trying to get to a class, and I stopped into the School of Public Health, Harvard School of Public Health, which is right on the campus by the medical school. And while I was there, I met someone who eventually became the chair of epidemiology at the Harvard School of Public Health, Alec Walker. And we started talking, and he got me interested in looking at some data that he had from England, King's College in England. It was glaucoma risk factor data. They had collected all this data and didn't have the expertise to analyze it. So he said that he would be my faculty mentor and we could do this work together. So I said, okay, well, sure, why not? The medical school, Harvard, required a concentration requirement at that time. It's sort of like a major in undergraduate school. You had to delve into something more deeply. And so I thought I would maybe concentrate in that. And so I did this analysis with Alec Walker on glaucoma risk factors. And it turns out that, I didn't know it at the time, but it turns out that risk factors was a very new thing. You know, it was really the Framingham health study, which was in the 1970s, in which risk factors was even a terminology that became used. And this was, very early. This was still when I was in med school. We're talking about 1976. And so it was really very, very new concept. And so I kind of became like a expert on risk factors in glaucoma. I probably knew more about it than just anyone in the country because it was so new. And so I decided instead of going into psychiatry and becoming a psychoanalyst, I would go into ophthalmology and continue my work with glaucoma risk factors. So I did that, and then after finishing my residency, I did a fellowship in glaucoma. And that's kind of how I got into medicine. How I got into epidemiology is that my medical school ophthalmology residency program, which was at Mass Eye and Ear Infirmary, we had a rotation in the Caribbean island of St. Lucia for 6 weeks at a time as a senior. And so when I was there during my rotation as a senior resident, I noticed that, I spent a lot of time on the beach like everyone else did when they went to St. Lucia, and befriended the beach guys a lot. And I noticed that, these are strapping young guys, and several of them I noticed going into their gym bags and putting a drop in their eye. And being an ophthalmology resident, I knew what the drop was. It was a glaucoma drop called Timolol. And I started thinking, well, why are they using Timolol? Because everything I had been told in the past in my training in ophthalmology was that glaucoma was a disease of older people. And these are guys in the 20s. And so I kind of I put that in the back of my mind and decided that I was going to look into that. So after I finished my fellowship, I went back to St. Lucia to be the faculty advisor. And during that time, I designed a study to look at this issue of glaucoma in Blacks and did a population-based study of glaucoma, prevalence of glaucoma in St. Lucia, and found that the prevalence was much higher than was reported in white populations at the time, population-based studies, and that glaucoma started at a much younger age. We know this, very well now. This is a well-known fact, but at the time, this was the first population-based study to actually show that. And so that kind of got me interested in epidemiology, as well as health disparities, because of the disparities between the white and Black population with respect to glaucoma. And so my career has really kind of been at the interface of ophthalmology and epidemiology. I should say, after that point, when I was at the when I was a faculty member, I went back to school as a faculty member to get a formal degree in epidemiology, but that was after I did my first major study. So most of my work has been in the interface between ophthalmology and epidemiology, and then more recently between medicine and epidemiology and health disparities. So that's how I got into both medicine and epidemiology. Is that pretty much what? Yeah. Okay.
Great. Thank you so much for your introduction. I think we're just going to go into like the questions and answers next. So the first question that we have for you is, how has your background in science and medicine influenced your current and prior leadership positions?
Yeah. So, in medicine, you train to approach problems in a very specific way. And in your training, you have to become very comfortable with the whole issue of uncertainty, right? Because you never really know something for sure. You usually have incomplete data. So you have to approach it by being comfortable with making decisions based on incomplete data, make a differential diagnosis based on the probability of each, and then formulating a definitive approach to how to deal with whatever the problem is. And as leaders, whatever the discipline is, you have to make decisions often without total information. So you have to be comfortable with being able to approach decisions without very complete information. And medicine kind of teaches you that. And it's really kind of the same thing in science when you really think about it, right? You have to learn how to formulate the right questions, develop a hypothesis, and then a plan for how you're going to attack that hypothesis. And so it's a very systematic way of approaching problems based on probability or likelihood. And I think that approach has served me well in whatever leadership positions I've had over the years.
Hi, President Wilson. The next question we have is, why do you think it's important for those with a STEM background to engage in science policy?
Yeah, I guess the first thing I would say is that to effectively engage in policy, whatever the area, one needs, first of all, to be familiar with and understand the issues in that area. And so a STEM background provides a person with a foundation to understand science, which is necessary, I think, to engage in good science policy.
Awesome, thank you. Our next question is, SciPol Detroit aims to bridge the gap between scientists, policymakers, and the general public. And given the wave of mistrust and misunderstanding around science right now, especially with COVID-19, what advice do you have for building that trust and reaching out to members of the lay public?
Yeah, well, let me say first of all that I am just utterly dismayed at the level of mistrust of science right now. You know, different types of sciences may have different levels of inference that's involved, but it's all based on data. So what's called the hard sciences, the physical sciences, are typically based on hard data. For example, the laws of gravity. Whenever apple dislodges from the tree, it's going to go down, right? It's never going to go up. That's just a hard fact. In some other sciences, particularly epidemiology, one must infer causality. For example, maybe an example might be smoking and lung cancer. It's not as clear cut. That may not be a good example because we pretty much know that smoking causes lung cancer now. But you can imagine it maybe in the early days that you had to infer causality, that smoking did cause cancer based on specific things. The exposure comes first, and then the disease. How much exposure you get, those kinds of things. And we don't always get it right? But ultimately, with data, we almost always do get it right. Think about, for example, let's say cholera and the origins of why people used to get cholera. It used to be thought that cholera was caused by bad air. And John Snow, and this is perhaps the classic epidemiological study, showed that no, cholera is caused by bacteria in water, contaminated water. And he showed this very elegantly. But it wasn't until many, many decades later that bacteria was discovered. So he inferred this based on his studies, but the whole concept of a bacteria wasn't even known at that time. It was many years later. And so, you may infer certain causality, and you may get it wrong sometimes, but ultimately we usually get it right. But the larger problem with respect to distrust is not that information evolves. For example, the use of masks, right? I mean, we know now for COVID-19, we know now that masks are very effective. But that was an evolution of data that brought us to that conclusion. And so one can become cynical and say, well, 5 months ago, not everybody was saying that. Well, yeah, but information evolves. But what's more important in terms of the distrust, I think, is when science is misused. And examples of that, for example, is phrenology to rationalize racism. That was the study of what the cranium, the size and the characteristics of the cranium to determine how smart you are and what kind of characteristics you have. And it was used to rationalize, that certain populations were just dumber than others and were just lazier and things like that. So, science being misused like that, or for example, the unethical experiments of Tuskegee syphilis study. And so when you have that kind of misuse of science, that causes some of this distrust. So you build the trust by always being guided by the data. That's number one. Admit when conclusions can change based on new data, because that's just natural. You have evolution of information, and you never misuse science. And I think those are the keys to combating this distrust that we have of science right now.
Yeah, just to follow up on that, we talked previously about this problem of scientific sort of misconduct and kind of the examples you mentioned. So in your view, is the onus or the responsibility on us as scientists and students of science to better communicate what we're seeing to the lay public, to, you know, take ourselves out of the ivory tower and actually use better methods of communication? Or do you think we need to start really early and push for public STEM education, especially in public schools and also private schools? Like, where do you think we can make the best impact?
Yeah, so I don't think it's an either or. I think you've got to do both. You know, certainly you've got to push STEM education in the public schools, and you got to do it the earlier the better. You know, we're finding out now that by the time you're in high school, it's probably too late. I mean, in many ways, you know, the foundational elements should have already been there. So you've got to start early, and I think that's an important part. But also, the other part you mentioned is very important. There are many brilliant scientists, you know, throughout the world, and I've met many of them, particularly at the NIH. You put them in front of people, lay people, and they can't speak or write in understandable terms to the lay public. And if you can't communicate in a very simple way to the lay public, then you're not going to be effective in advancing policy, because when you really think about it, you know, most people who make the decisions, legislators and others, are not scientists, and they don't know scientific terms. And it's amazing how, you know, a brilliant scientist can do so well when talking to their colleagues, and you know, all these acronyms and these brilliant ideas, and you put them in front of a funder, whether it's pitching private philanthropy or legislators, and they talk in terms that are just not understandable to most people. And so it's not a either or. It's actually both.
Yeah, thank you for that answer. It's actually the foundation of Science Policy Detroit. So thank you for that. Our next question is, in your experience, which strategies have you seen make the most impact in the Detroit community?
Yeah, you know, one of the things that I'm just amazed by, and I'm sure you've heard this because it was recently mentioned in the Detroit News. You know, early on with the COVID-19, there was a huge racial disparity, right, in both the, you know, who got the COVID-19 and who died from it. And Blacks particularly were at a huge increased risk for both getting it and dying from it. And then recently, it was reported that that disparity has basically been eliminated with all the more recent data. And that's been true since about mid-June. When you look at the percentage of COVID-19 cases among African Americans, it's basically, you know, actually, I hate to say this because it's almost unbelievable, but the latest report shows that African Americans are about 15% of the population of Michigan. And initially, they were getting about 40% of the deaths, and about that in terms of the numbers, percentage getting the COVID-19. The most recent data shows that they're about 8% of the COVID-19's contractions, and a little bit higher, maybe around 11 or 12% of the deaths. But still, you know, actually even lower than the 15% that you would expect if there was parity among all populations. And so that to me is just remarkable, that there's been this huge turnaround. So I think that's one good example. I think another in terms of strategies is the focus on zip codes, and in understanding that what, you know, really determines health is more a function of the social conditions under which one works and plays and lives than the actual physical care that one gets. And so using zip codes to identify vulnerable populations.
Yeah, just to follow up with that, do you think that the decrease in percentage of African Americans affected by COVID-19 had to do with local initiatives and, you know, the resources that were provided in the city of Detroit right away?
Yeah, I think there was a combination. I think certainly one of the things that was done was that the governor acted very quickly and put up this task force, the coronavirus racial disparity task force, and I'm on that task force, and I can tell you that it's a task force that is very action oriented, and it meets every week, but it doesn't meet and just talk. I mean, there's really real action that is determined, and you know, one of which was to do mobile testing in these vulnerable communities, and Wayne State has been, you know, very involved with that. So I do think, you know, some of it has been based on some actions taken by the task force, better communication. You know, in the early days of the pandemic, there was a rumor that Blacks couldn't get COVID-19, that they were immune from it. And I don't know where that came from. I heard some theories about it, but it was rampant. And so, you know, I had people tell me that Blacks couldn't get it. But so there was a communication blitz that had to be planned and implemented that went against, you know, that kind of misinformation. So I think those kind of things were very helpful. But also, I think what happened is that the shock of seeing so many friends and family members among the African American population succumbing to the disease made African Americans much more aware of the risks and perhaps, and this is anecdotal, but more likely to persist with the mandatory mask, social distancing, and some of the other recommendations and mandates that have come down. So it's probably a combination of things.
Thank you for bringing up those examples. At our last Science Policy Detroit meeting, we discussed the importance of supporting science and public health funding at a federal level. So given that public institutions such as Wayne State rely heavily on federal funding, what are ways in which students and scientists can better advocate for public science funding?
Yeah, so let me break that up into students and then scientists. For the students, I think having your voices heard is the most important thing. You know, legislators particularly love students. They just, you know, if I go in and talk to them, they'll maybe pay attention to me, but if you go in and talk to them, they will pay attention to you. They love students. And so to have a student actually go and personally advocate is very effective. In terms of scientists, we've already talked about this, but I don't think a lot of scientists, and many are better at it now than in the past, but I don't think a lot of scientists know how to communicate to the lay people and know how to lay the case for why certain things could be supported. And again, as I mentioned, remember that most legislators and most other decision makers related to policy are not scientists. And so got to be able to talk in a language that is really relevant to the average person and be able to communicate it in a way that is compelling. And that's a skill. That's a skill that scientists, by and large, are not trained for.
In addition to that, your experience as former deputy director at the NIH for the National Institute of Minority Health and Health Disparities, how did that shape your current views on science policy and in terms of funding and just in general?
Yeah, so, NIH is a funding agency. It's the largest funder of biomedical sciences in the world. So it's primarily a funding agency, but it is also a policy agency. The policies related to scientific research throughout this country, because of it is such a heavy funder of that research, they have a lot of influence in terms of policy. And so it's also a policy agency. In my time at the NIH, made me really understand for the first time the influence and the power of policy, particularly science policy. My son, when he was a little boy, he used to tell me sometimes. He said, "Dad, when you were seeing patients, you were helping people and helping people see." Because I was an ophthalmologist. He says, "Now all you do is sit behind a desk and push paper around." I said, well, I told my son's name is Yoshua. I said, "Well, Yoshua, I'm still helping people, but it's different. It's more through policy." And then I try to explain the difference and how it affects so many people, versus just the person who's sitting across from you that you're examining. And I think he kind of got it, but I think he gets it now. But the influence of policy is something that I understood, but not quite as well as when I was actually at the NIH. And for the first time, people were wanting to see me, right, from all over the country, to have meetings with me, because I could influence some of that policy that they were interested in, the same way that you're interested in influencing policy, and you go and you write letters and you see certain people. I was on the other side of that balance, so to speak. And so I really got to understand the power of scientific policy at that time.
For sure, that's a great experience. So like you mentioned, you were appointed to Gretchen Whitmer's Michigan Coronavirus Task Force, specifically working on racial disparities. And we were just wondering, could you provide more of an overview of your experience with that task force and what it was like merging your scientific background with the policy making that was involved with this task force?
Yeah, so there was two task forces, right? One was the Michigan Coronavirus Racial Disparity Task Force, and the other one was the Healthcare Advisory Group of the Michigan Economic Recovery Council. That was a council made up of leaders in healthcare, but then another one that was leaders in business, and then together, we've tried to advance a few things. I think you saw the message or the letter that we wrote recently that was published in Crain's today and yesterday, actually, asking the governor and the legislators to kind of work together and come out with a unified message related to COVID-19. And so that's sort of a different role than what we started off, which was advising the governor on different looking at the data and advising the governor on what she should open, what she should not open, based on the data, specifically just the data, and not so much other political considerations. But now that the governor's emergency powers have been stripped away by the Supreme Court, we felt that we still had a role in terms of more advocacy for what we think, based on the data, is what the people of Michigan could benefit from. And that's why we wrote that letter. On the racial disparities task force, as I mentioned, it's been a very action-oriented task force. I mentioned the mobile testing, and the communication strategies, but there were a number of other things, some grants and things like that that they put out. And I'm hoping that with the success that task force has had in terms of decreasing the racial disparity in COVID-19, that we could leverage that success into other areas that could impact, other health disparity areas. This was, I look upon the COVID-19 as just a microcosm, I guess, of the larger health disparity issue. And because, when you think about most health disparity issues, the prevalence is not that high on many other things, and it takes a long time to come to the outcome, or particularly death. Hypertension, for example, you could have it for decades, or diabetes, decades, and so you don't see the outcome until much later. Whereas with COVID-19, the outcomes were very, very short. And so it magnifies the effect of the racial disparity. And so you're able to then focus on these areas in a way that it was difficult to focus on something that takes decades to see the outcome for. But I think you can learn lessons from that and apply it to the larger picture. And I'm hoping that's what we end up doing after COVID-19 is no longer with us.
Thank you for that response. So the last question from us is, so Science Policy Detroit is made up a lot of students and scientists, and we are looking for ways to make a difference. So which activities or policy focus areas do you think are most important for creating a cleaner, safer, and healthier Detroit?
Yeah, that's a great question. One of the things one of the health disparities that in Detroit is that related to asthma. We have one of the highest incidents of asthma in the nation. And it disproportionately affects people of color in our city. And so there certainly is a need to target environmental issues that cause these health disparities. In the case of asthma, we need to reduce air pollution in Detroit and in Southeast Michigan. Different ways of doing that, including, some of the work that's being done with the auto industry, stricter enforcement of air permit violations and things like that. But that's certainly one area that has to be looked at. The other is that we're blessed to be so close to a great natural resource, and that's the Great Lakes. And but the Great Lakes is not a resource that is going to always be there unless we take care of it. And there's a lot of contamination going on right now. And a lot of it has long-standing effects on human health. And so we really need to look at some of the Great Lakes watershed issues, the contamination with PFAS and other byproduct chemicals from, non-stick cookware and other consumer products. This is a real environmental danger. And so I think that those are two areas that of focus that I would, I think will be particularly important for the area of the country that we're living in. And in terms of the other part of your question, how you can be most effective. My experience at the NIH, when I was mentioning that the first time I was kind of on the other side of the ledger where people wanted to see me instead of me wanting to go see people and try to get something, right? Whether it's funding or whatever. And, I'm used to asking for money. And, for the first time I had people asking me for money, so it's a different experience. And what I would tell you is that the thing that I found to be most effective, because I would get dozens, if not hundreds, of letters from people, but the thing that I found to be most effective was a personal visit. And a personal visit, often with, if they were accompanied by someone that I knew, was perhaps the most effective, because there was a level of trust there, because I know the person, and if they're accompanying someone, then you start off the relationship or that meeting in a more trusting way. And so I would say identifying people who have access to the people you're trying to influence, and actually making personal visits is one way of being effective.
Thank you for that. I just wanted to piggyback and say that all of your tips and your areas of focus for being action oriented are very helpful for us. That's something that I think everyone on this phone call wants to do. We want to do something that actually makes a difference. So, putting students in the forefront and giving them the opportunity to talk to lawmakers and making those personal connections, that's something that we're hoping to do over the course of the next year. So arranging Lansing visits where we can actually make those personal connections, working with other groups across the state who are doing that, and even on campus, like the Cure Center here, writing to lawmakers. That's something that we're trying to do after almost every meeting. And then hoping once, like you said, COVID calms down, we can actually invite lawmakers onto campus and give them lab tours and see what, folks at Wayne State are doing. So just thank you for those ideas. Those are really helpful.
And do you have any relationships or have you coordinated at all with the Patrick Lindsay and his team, the VP for governmental, state and federal governmental affairs?
No, we have not, but we will definitely reach out now. Thank you.
Yeah. I think that he could be a really good resource for you, because he's got lobbyists, he's got other people who work at both federal and state level, but you'd be more interested probably in the state level, that work, on behalf of Wayne State, but they can help in terms of helping you set up, get entrance to, meeting people, helping to, arrange visits of legislators and things like that. So you should definitely use them as a resource. Now, obviously, they've got, their own priorities in terms of what they're trying to get done too, but I'm sure that they would be very, very helpful.
Thank you.
So for the Q&A, our first question comes from Lana Grazer.
Hi, Dr. Wilson. Thank you so much for being here today, and for the SciPol Detroit team for putting this together. My question was in regards to how research can be structured to better serve target populations of research. So that is, when we are conducting scientific research within a given community, how can we simultaneously be giving back to that community and ensuring that our research methods and our directives reflect the realities and the needs of these communities?
Yeah, great question. I think one of the things I would point you toward in terms of an example is what we decided to do in our iBio building, our new research building. I say new, it's not that new anymore. It's been around, it opened up around the same time that I came here 7 years ago. But we decided, it was brand new, and it was an empty building. So we decided that we were going to focus on certain types of research, and specifically on research that makes an impact on the community of Detroit. What are the main issues affecting Detroit from a health standpoint, and then tackling those areas. And so we picked 5 focus areas, and did something which is somewhat unique. In fact, I shouldn't use the qualifier somewhat, which was very unique, in that instead of then recruiting people the way most recruitments were done in the past within departments, we decided that we were going to do cross-cutting, interdisciplinary recruitment based on these specific focus areas. So, for example, diabetes. When you think of diabetes, you may think about the chemical imbalance and more from that standpoint, the physiologic issues related to diabetes. But it's more than that. It's psychological. It's social. It's issues of obesity. Play into it, and so to tackle something like diabetes or obesity is another one. You've got to approach it not from just one angle, not just from a physiological, but from a psychological and from a sociological, and therefore we would recruit based on the focus area, but it could be from people from totally different disciplines. So from sociology or from psychology or something, but they will all be focused on trying to solve issues of that particular disease or condition. And that was a conscious decision that we made. And I think that we've been fairly successful at it so far.
Thank you.
Well, thank you for your question, Lana. Our next question is from Max Denny.
Oh, wait, you want to read it? Okay. Yes, so I was just wondering about if you have any belief that science policy should actively be disputing or addressing pseudoscientific claims and practices.
Pseudoscientific claims?
Yes.
Well, I think that there's a role for somebody or some entity doing that, kind of like a fact checker, right? I love when they have these fact checkers on TV these days. But I don't know if that's specifically in the wheelhouse of science policy per se. I think that somebody needs to do it, but I guess I'm on a couple of boards that related to science policy. One of which I just joined yesterday, in fact, Alliance for Health Policy, and our focus is going to be specifically policy, and allow others with other focus areas to dispute the validity of certain claims that I made, and it's just a pragmatic issue of how much time you have and how much resources you have. And so, we feel that our focus our time and resources could be better spent by focusing specifically on policy. But again, it's a resource question, and we all have limited bandwidth, and how much can you take on? But somebody needs to take that on, and whether, but it's probably better done by a group or by people specifically focused on doing that, and you focusing on science policy. Just my opinion.
All right, thank you very much.
Well, we just wanted to thank you so much, President Wilson, for joining us today and answering all of our questions. For the rest of the audience, if you have any questions, please email us. But I think that wraps it up for today. So thank you so much.
Okay.
And thank
I
you for your
enjoyed it. Yep. Thank you. Bye-bye.
Thank you.